Schizophrenia is probably the most severe and potentially disabling form of mental illness in every community worldwide. It may present as an acute or chronic illness. The clinical features include characteristic positive or negative symptoms, deterioration in social, work, or interpersonal relationships, and continued evidence of disturbed behavior for at least 6 months. The clinical features um, may be numerous and can change over time. Psychosis associated with substance abuse and mood disorders with psychotic features may mimic schizophrenia. For this illness, a few people may recover completely after an episode or two, and treatment must be started once the symptoms are present. A definitive diagnosis and establishment of a treatment plan is best carried out by a psychiatrist. Treatment for acute episodes can be started by a psychiatrist, and follow-up treatment continued by most caregivers. So treatment must be for at least 18 months after remission of symptoms for a first episode. However, lifelong treatment is probably the best strategy to avoid recurrence. Side effects such as pyramidal reactions like slowness, drooling, stiffness, tremors, rigidity, muscle spasms, including tongue sticking out, neck bending, and others to antipsychotics may occur, especially when administered at high doses. These adverse reactions can be prevented or managed with anticholinergic agents, which must be used sparingly, as they may contribute to the development of another adverse event called tardive dyskinesia or tardive dyskinesia in the long term. So the causes are largely unknown. Possible associations are biogenetic. It has to do with dopamine and serotonin receptors, biopsychosocial determinants, genetic predisposition coupled with stress, economic disruptive family environments, among others, and birth defects in brain associated with season of birth, possible viral infections, also environmental triggers and illicit drugs, marijuana, amphetamines. Symptoms or signs. So the positive symptoms are hallucinations, for example, hearing voices, that's auditory hallucination, delusions, that's stated beliefs which cannot be substantiated, and incoherent speech or illogicality, and also odd or disorganized behavior. Patient believes his or her thoughts are controlled by outside forces. Also, negative symptoms like poverty of speech or content of speech, few words or with little substance, apathy, reduced social contact or withdrawal, flattened affect, showing little facial expressive responses, and delusions. They may be persecutory, such as undue suspicion, and also total bizarre, like being controlled or being made to feel emotions or sensations. Grandiose delusions may also occur, but without the elevated mood seen in manic patients. Also, hallucinations, commonly auditory, but may involve any of the other senses. Also, auditory hallucinations of multiple voices commenting on patient's actions, arguing about the patient, almost diagnostic. Also, motor disorders like prostrain, excitement, or stupor may occur, but not essential for diagnosis. Investigations, usually none required for diagnosis, tests to rule out organic causes of psychosis, and baseline full blood counts, blood sugar, lipids, liver and kidney function tests for purposes of guiding treatment. Also for olanzapine and risperidone, ensure that fasting blood sugar, lipid profiles, liver and kidney function tests are carried out at least twice a year. Treatments. So the main treatment objectives are to abolish symptoms, to restore functioning to the maximum level possible, to reduce the chances of recurrence, to monitor blood glucose, lipid profiles, liver and kidney function at least twice a year for patients on olanzapine and risperidone. Non-pharmacological treatments, supportive psychotherapy, rehabilitation, family therapy, psychoeducation about the cause, treatment, side effects, and relapse prevention. Also, behavior therapy, for example, social skills training, progressive muscle relaxation, coping skills. Pharmacological treatment, first-line treatment in the management of acute attacks. We give olanzapine IM oral in adults 5 to 10 milligrams stats and then 5 to 10 milligrams daily with a maximum dosage of 20 milligrams daily. In children more than 12 years, we give 5 to 10 milligrams stats and then 5 to 10 milligrams daily with a maximum dosage of 20 milligrams daily. Less than 12 years is not recommended. Or you can give chlorpromazine IM in adults 25 to 50 milligrams 6 to 8 hourly and adjusting to a maximum of 400 milligrams daily. In children 12 to 18 years, if 25 to 50 milligrams 6 to 8 hourly and adjusting to a maximum of 400 milligrams daily. And then 6 to 12 years, we give 500 micrograms per kilogram 6 to 8 hourly to a maximum of 75 milligrams daily. 1 to 6 years, if 500 micrograms per kilogram 6 to 8 hourly to a maximum of 40 milligrams daily. Or you can also give chlorpromazine oral in adults 25 milligrams 8 hourly or 75 milligrams at night, and then according to response you adjust appropriately. So adjust according to response to 75 to 300 milligrams daily. In children more than 12 years, you give 25 milligrams 8 hourly or 75 milligrams at night, and then adjust according to response to a maximum of 75 to 300 milligrams daily. In 6 to 12 years, you give 10 milligrams 8 hourly and then adjust according to response to a maximum of 75 milligrams daily. And 1 to 6 years, you give 500 micrograms per kilogram 4 to 6 hourly, then adjust according to response to a maximum of 40 milligrams daily. Or you can give haloperidol IM in adults 2 to 5 milligrams that, and then repeat 4 to 8 hourly according to response to a maximum of 20 milligrams daily. In children 6 to 12 years, give 1 to 3 milligrams 4 to 8 hourly as required, and less than 6 years is not recommended. You can give haloperidol oral in adults 0.5 to 5 milligrams 8 to 12 hourly daily, and then 5 to 10 milligrams 8 to 12 hourly with a maximum of 30 milligrams. In children more than 12 years, we give 0.5 to 5 milligrams 8 to 12 hourly daily, and then 5 to 10 milligrams 8 to 12 hourly with a maximum of 30 milligrams. And 3 to 12 years, or body weight 15 to 40 kilograms, give 0.25 to 0.5 milligram daily, and then increase by 0.5 milligram daily every 5 to 7 days. Less than 3 years is not recommended. For the maintenance dose, we can give risperidone. So risperidone oral in adults 1 to 4 milligrams 12 to 24 hourly. Starts at low dose and adjust daily according to patient's response. Or you can give olanzapine oral in adults 5 to 10 milligrams, the maximum of 20 milligrams daily. In children more than 12 years, give 5 to 10 milligrams with a maximum of 20 milligrams daily, and less than 12 years is not recommended. Or you can give chlorpromazine oral in adults 25 milligrams 8 hourly or 75 milligrams at night, and adjust to a maximum of 200 milligrams 8 hourly. In children 12 to 18 years, give 25 milligrams 8 hourly or 75 milligrams at night, and adjust to a maximum of 200 milligrams 8 hourly. Less than 12 years is not recommended. You could also give haloperidol oral in adults 1 to 3 milligrams 8 hourly, and adjust to a maximum daily dose of 20 milligrams. In children 12 to 18 years, you give 1 to 3 milligrams 8 hourly, and adjusted to a maximum daily dose of 20 milligrams. And 3 to 12 years, you give 500 micrograms 12 hourly, and adjust up to a maximum of 5 milligrams 12 hourly. The maintenance treatment for patients with recurrent or chronic illness, that's the depot preparations. You give flufenazine decanoate. So flufenazine decanoate, you give IM in adults 25 milligrams monthly. In children is not recommended. Or you could also give flupentazole. So flupentazole decanoate, you give IM in adults. You give test dose of 5 to 20 milligrams, and after at least 7 days, you give 40 milligrams daily. In children is not recommended. Adjunct treatment for management or prevention of antipsychotic drug side effects. So you can give benzazole, that's trihexyphenidyl oral. So in adults 2.5 to 5 milligrams 6 to 8 hourly, with a maximum dosage of 20 milligrams daily. In children 6 to 18 years, give 0.5 to 1 milligram 12 to 24 hourly, and then you increase every 3 to 7 days by 1 milligram daily according to response. You could also give benztropine oral or benzatropine. So benztropine oral in adults 1 to 2 milligrams 8 to 12 hourly, and in children more than 3 years, give 20 to 50 micrograms per kilogram 12 to 24 hourly. Or could also give piperidine oral. So piperidine oral in adults 1 milligram 12 hourly, and then adjust to 2 milligrams 8 hourly up to 4 milligrams 8 hourly. In children is not recommended. Or you can also give piperidine slow IV or IM in adults 2.5 to 5 milligrams, and adjust to a maximum of 20 milligrams in 24 hours. Or you can give benztropine IV or IM in adults 1 to 2 milligrams slowly over 2 to 4 minutes. Repeat if symptoms persist after 8 to 12 hours. Or you can give diazepam oral in adults 5 to 10 milligrams as 6 to 12 hourly, and in children, um, 12 to 18 years, we give 10 milligrams 12 hourly, or 5 to 12 years, we give 5 milligrams 12 hourly, or you can give diazepam IV in adults, 5 to 10 milligrams slowly over 2 to 3 minutes, approximately 2.5 milligrams every 30 seconds. And in children, 200 to 300 micrograms per kilogram slowly over 2 to 3 minutes. And this may be repeated 10 minutes. Or you can give promethazine hydrochloride oral or IM in adults, 12.5 to 25 milligrams initially, which may repeat dose if symptoms persist after 6 hours. In children more than 6 years, we give 6.25 to 12.5 milligrams, and then repeat dose after 6 hours. Less than 6 years is not recommended. Referral criteria: refer all patients to a psychiatrist after an acute episode if treatment was initiated without a psychiatrist's supervision. Likewise, refer all patients with recurrent episodes and those whose symptoms cannot be controlled to a psychiatrist for further drug treatment or electroconvulsive therapy.